Hello friends, I am Dr. Sourabh Patwardhan from Nandadeep Eye Hospital PG Teaching Institute and Phaco SICS Training Center, Sangli, Maharashtra, India. In our center, we have a lot of teaching activities which includes hands-on training as well. Let's begin discussing this case of Phacolytic glaucoma and can I do better next time in similar case. So as you can see, this patient has come to me with raised IOP. Cornea is all hazy. We have controlled the IOP with IV mannitol and oral as well as topical anti-glaucoma medication, and of course the final treatment for phacolytic glaucoma is to remove the cataractous lens. So I have washed out all those debris from the anterior chamber. So in phacolytic glaucoma, usually you find a Morgagnian cataract sitting behind, and the proteins which have leaked from the anterior capsule cause the raised intraocular pressure as they block the trabecular meshwork. Similarly, you will have similar debris behind the posterior capsule, which you will see very shortly. So the anterior capsule has been stained here. In Morgagnian cataract, one is worried about having a good capsulorhexis. There is a possibility that we may have weak zonules in these cases. I always use a good heavy dispersive agent like Viscoat or Hylucoat for such cases, and for capsulorhexis it's best to use the capsulorhexis forceps. So when you do capsulorhexis, generally you judge for the integrity of the zonules. So I am using a micro capsulorhexis forceps here, and the rule here is that always pull the capsulorhexis tear tangentially, never tear it centripetally in such cases, because if zonules are weak it will break more zonules. So you can see I am changing grip all the time so that I always pull this capsulorhexis tear tangentially and never centripetally. Going ahead with the phaco, the plan is to do horizontal chop. First I make a small tiny groove using Ozil, and this gives me a kind of a grip, and now I am going to use longitudinal bursts of phaco, and that's my 1.5 mm long Sinskey which does the horizontal chop, and try to split it completely. Using longitudinal bursts give you much better hold on the nucleus, and then you can see that 1.5 mm Sinskey goes around the equator of the nucleus, which is already shrunken, so it's easier to do horizontal chops here. Just make sure that you don't lose the hold and you don't cut across the nucleus, then posterior capsule may be damaged. So you can see that this 1.5 mm long Sinskey works beautifully in such cases, and it's blunt, so even if you touch the posterior capsule it is not going to rupture it. And split this nucleus into multiple halves and then start removing them one by one. You can replenish the dispersive OVD in between, and now I have shifted to the quadrant removal mode where I am going to use Ozil with some IP, that is in between longitudinal pulses. I am using, it's a balanced tip, so I am using 70 to 80% of the Ozil power with 10 to 20 pulses, but nowadays I have reduced it to 5 pulses per second, which works great. And here you can see that those debris, so those are behind the posterior capsule, so you can appreciate that the posterior capsule is in fact coming too anteriorly, and that's why I stopped. I replenished the OVD, and as I pushed more OVD you can see that those debris got dispersed because those are collected in the anterior vitreous. Now I am pulling all those pieces in the center so that I can complete the emulsification. Now here I feel what I could have done is use the scaffold technique. You can see that posterior capsule which is coming dangerously close to the phaco tip, though I am going on with the phaco. I am using Centurion phaco machine, so I feel the anterior chamber maintenance is still better. But I think in this case as well, so in future if such situation arises where the the posterior capsule is redundant and coming too anteriorly, too close to the phaco tip, it's better to implant IOL in the bag because there will be hardly any cortex left later, and then complete the phacoemulsification. Here I would say I was little lucky that I didn't touch the anterior capsule with phacoprobe, but the margin for error was very minimal, and little punch or little touch to the posterior capsule and I will have a open posterior capsule here. So I think that's a lesson for me for the next time. If such situation arises, I think I would better put a IOL in the bag first and then take out remaining nuclear pieces. Cornea appears quite clear now once I have removed the debris, but in such cases we expect that there will be post-operative corneal edema which will stay for a little longer, and you may have to give topical steroids as well as anti-glaucoma medication till everything comes under control. Many of these patients may not require, you can see that I was trying to remove the cortex, but that is not the cortex, it is behind the posterior capsule, and there is a little bit of pseudo exfoliation material which is on the anterior capsule. So you have to be very careful in such cases. Sometimes there is a temptation to try to remove that posterior exudates and you tend to damage the posterior capsule. Here I was just a little bit suspicious whether there is still posterior capsule there or I have opened it, so I just used the Sinski to touch the posterior capsule, and you can see just like trampoline you can feel the membrane there, and now the IOL has been implanted. It's a small pupil already, so it's important to check that both the haptics are in the bag before you close. So few things for me also to learn when I watch the video again, and use of horizontal chop using 1.5 mm long Sinski is a great idea. I'm sure that you will learn from this case. Do subscribe to my YouTube channel and do comment. Thank you.